Analysis of Facial Beauty, presented by Shin. I am going to review 3 journals during this session. The first journal, The Application of the Divine Proportion for the Construction of the Visualized Treatment Objective in Craniofacial Surgery. Introduction. Aesthetic and function of maxillofacial district closely related to patient psychological condition. The aim is to describe and analyze procedure for visualized treatment objective, VTO, realization through use of tracing on lateral head film, applying divine proportion, golden ratio. This is an easy and cheap method to use. The surgical VTO has been divided into 11 steps. This facilitates communication between orthodontist and maxillofacial surgeon to each other and patient. Visual treatment objective, VTO, consists of a pre-visualization of an objective in order to make the desired changes for individual patient. The result can thus be visualized and pre-evaluated rather than just imagined by the mind's eye. This technique proves to be effective in planning surgical treatment, and it allows the clinician to view changes before, during, and after orthognathic surgery. The skeletal, dental, and aesthetic complete cephalometric evaluation is the key point to the long-term success of the result. Beauty is an advantage in a society for the development of one's own identity, for the growth of one's self-esteem, and therefore for the climb towards success. Aesthetic is the study of beauty and psychological responses as consequences. Like every phenomenon, it could be represented on a Gauss curve, which allows to define its statistical distribution. Considering the statistic, the peak of the curve in 0 corresponds to perfection. Everything that is distributed beyond the second standard deviation is perceived by the human eye as unpleasant. Actually, the face contains a basic order called golden cut, golden section, or divine proportion, and it is perceived by the limbic system. It is important to understand and determine the aesthetic defect and then select the best treatment alternative for the patient. Rickett calls the chain diagnosis, prognosis, projection, treatment planning. The need for orthognathic surgery to correct skeletal as well as the occlusal discrepancies has increased as more adults are presently soliciting orthodontic treatment. The indication for surgical orthodontic treatment is that a skeletal or dental alveolar deformity is so severe that the magnitude of the problem lies outside of the envelope of possible correction by orthodontics. The golden divider, proposed by Ricketts in 1981, is a useful device for clinical application for golden section. The left figure may be used for teeth, skeleton, soft tissue, faces, morphological, cephalometric analysis. Upon widening the divider, a short side and a longer one can be proportionally measured as the divider is extended. Accurate prediction of surgical outcome is of paramount importance in the treatment of dental facial deformities. These predictions have a purpose like a guide the treatment to the desired result, to give the patient a reasonable preview of the outcome, and to serve as well as a communication tool between the orthodontist and surgeon as well as the patient. Therefore, the treatment goal displayed are important predictive tool used to visualize the goal before, during, and the end of the treatment. This visualized treatment objective, VTO, which is renamed by the Ricketts Surgical Treatment Objective, STO, usually involves a manual surgical simulation based on cephalometric X-ray imaging. The purpose of this article is to describe and analyze step by step the procedure necessary for realization of a correct STO through the use of lateral cephalogram or a lateral cephalogram, like derived from a cone beam computed tomography volume, which this two-dimensional movement and this technique is very cheap and effective, as I mentioned earlier. So this journal has a target question, which are two. When and why is it necessary to perform surgical STO on dental patient? And also another question, how to perform a proper surgical STO on dental patients. In order to understand and follow the reasoning, methodology, and findings, it is imperative that the certain anatomic points and landmark be explained. So let's look at the figure A, reference for tracing. Figure B, cephalometric tracing. So cranial reference contains, there are 6 of them, basin, nasion, porion orbital, pterygoid point, and center cranium. There are mandibular and maxillary reference to look at. Mandibular reference has 6 components, Pogonian, protuberance menti, Gnathian, menthin, and xi, subgonian. Maxillary reference contains 3 components, anterior nasal spine, posterior nasal spine, point A. Teeth and soft tissue. Teeth has 4 components, lower incisor, which is indicated as B1, upper incisor, which is indicated as A1, lower first molar, which is indicated as B6, upper first molar, which is indicated A6. And soft tissue is a smaller letters are employed for reference. The result contains the improvement in appearance is an important motivation for patient to seek orthognathic treatment. This motivation for treatment that affects facial aesthetic is linked to psychological and social factors, which the quality of life has improved for a patient who has undergone surgery due to increased self-esteem and self-confidence. Social and psychological concern, which improve function, appearance, and self-esteem, may encourage the patient to undergo surgery. Therefore, it is great importance that the patient understands the outcome of the treatment. Cephalometric prediction plays an important role in orthognathic surgery by increasing patients' understanding and acceptance of the recommended treatment. In this journal, there are 3 cases selected. The first one is a bimaxillary case. Second one is a maxilla advancement with a repositioning of the mandible. Last one shows the genioplasty. The first case is a male, 25 years old, with a severe sagittal and vertical discrepancy used to show how to predict the movement, both upper and lower jaw. First of all, performing cephalometric tracing with the point and plane above the mention and the divine proportion analysis to, or simply use the golden divider in order to visualize the disharmony. The second case is a female 20 years old with a severe sagittal discrepancy and the severe open bite selected to demonstrate the method forecast the movement of the upper jaw and the consequent adaptation of the mandible. Perform the divine proportion analysis and focus the incongruity by the use of the golden divider. The third case is a female 18 years old with a convex profile, strain of a mentalis, and excessive convexity, choosing to prove the method to forecast the genioplasty. The divine proportion analysis shows an excess of the vertical dimension. This is a cybernetic circle of STO. Look at the first. Number 1, depth of an arch, lower incisor, 3 upper incisor, 4 mandible, 5 upper jaw, and 6 soft tissue, STO surgical treatment. It is widely accepted that the orthodontic movement of the teeth could alter the aesthetics. Orthodontists have tried to describe beauty, but they have also tried to predict how the orthodontic movement of the teeth affects existing facial balance. Orthodontists have suggested that occlusion and the beauty of the face are independent. Beauty is the phenomenon of the pleasure through the perception of balance. Facial beauty implies social success and has a positive influence in all areas of modern society. Facial aesthetics do not depend on any single feature. The golden section is said to have the unique quality in the description of beauty, harmony, and balance. This proportion is also linked to growth, and it is associated with optical function. Hence, it could be used for the analysis of harmony, structural balance, and can be applied for planning of orthodontic, orthopedic, and soft tissue treatment in dentistry, as well as in the maxillofacial plastic surgery. The analysis of golden proportion allows to highlight the presence of incongruous or disharmonious structure, allowing a sophisticated and reliable surgical planning. There are 4 main factors that may be used in the evaluation of the facial aesthetic analysis. The first one is the skeletal factor, and the second one is soft tissue. The third one is dental ratio. The last factor is the type of personality and the attitude of the patient involving the character of an individual. Functional beauty and the desire for improved psychosocial adaptation drive patients to undergo orthodontic surgery more frequently, which the success of the case requires constant communication between the orthodontist and the surgeon to correct diagnosis made through clinical radiographic evaluation. The study of the model cephalometric surgical prediction. The critical aspect of the method arises in the prediction of soft tissue reaction to skeletal change, which are in turn dependent on the positioning of the teeth. Total aesthetic planning consists of tooth movement together with the skeletal changes. Hence, the comprehensive skeletal, dental, and aesthetic cephalometric evaluation is the key point to the success of the result. This technique proves to be useful and effective in surgical treatment planning and allows the clinician to evaluate the changes before, during, and after orthodontic surgery. So there is a second journal that I'm going to review, which is called Perception of the Orthodontist, Lay Persons, and Patients Regarding Buccal Corridors and Facial Type. So the buccal corridor is a bilateral space between the commissure of the mouth and the buccal surface of the last visible tooth. These spaces are very important for smile aesthetics, especially when the person smiles. The majority of the study used the buccal corridor linear ratio, which is BCLR, to indicate the size of the buccal corridors. BCLR is the percentage of the sum of the distance buccal corridor width to the distance of the corner of the lips. Yang stated the second dimensional area index, which is called buccal corridor area ratio, BCAR, the ratio of the sum of the bilateral buccal corridors area to the total smiling area, is more accurate than the first dimensional linear index of BCLR because of the buccal corridors are two-dimensional on a frontal view. Thus, BCAR is used more frequently among orthodontists nowadays. So the patient-driven treatment planning has gradually become the mainstream of the orthodontic treatment. Orthodontic patients have more requirements for aesthetic than the layperson without orthodontic treatment needed. If the aesthetic perception of the orthodontist and the patient are not congruent, the orthodontic result may not be accepted by the patient, even if the patient occlusion function has improved. It is very important to orthodontists to consider aesthetic perception of patient when determining treatment plans. A female and a male model were selected with a facial convexity between 165 and 175, with an individual normal occlusion, ideal smile arc, ideal smile line, and healthy periodontal situation. So 2 models were taken from the full face photograph, which were digitally modified and then used for this research. A visual analog scale, VAS, with a 10 centimeter was used to assess attractiveness. It was anchored on the left at very unattractive and on the right at very attractive. So there are 6 orthodontists, 6 laypersons, 6 orthodontic patients invited to evaluate the attractiveness of photograph by VAS after VAS usage training. The median values and ranges of score given by 3 groups, raters, are shown in Table 1 and Figure 3. The orthodontist preferred 1% to 10% buccal quarter on the female model with a brachial, facial, and dolichocephalic, and on the male model with a brachis, facial, and mesofacial, and 1 to 5% buccal quarter on the female model with a mesofacial. They were unable to differentiate the degree of the buccal quarter on the male model with a dolichofacial except when the quarter was 20%. The laypersons prefer 1 to 5% buccal quarter on a female model with mesofacial and dolichofacial. 1% to 10% buccal quarter on a female model with brachiofacial, and 5 to 10% buccal quarter on a male model with a dolichofacial. They were unable to distinguish the degree of the buccal quarter on a male model with brachiofacial and mesofacial. When the orthodontic patient judged the female model, they preferred brachiofacial with 1 to 5% buccal quarter, mesofacial with a 5% buccal quarters, and dolichofacial with a 10% buccal quarter more attractive. When they judged the male model, they preferred dolichofacial with 1 to 5% buccal quarter and mesofacial with 1 to 10% buccal facial. Conclusion: in our study, there is no significant difference between the rating of the orthodontist layperson when evaluating female model except 20% buccal quarter in brachyfacial and mesofacial. The score of 3 groups decreased as the buccal quarter became large, but the rating of the orthodontist decreased more when the buccal quarter was 20%. The perception of orthodontist and the layperson for the female model are similar, but orthodontists have a higher sensitivity to changes of the buccal quarter. The large buccal quarter seems not to be the very important factor in the smile attractiveness evaluation for layperson and orthodontic patient. So in conclusion, orthodontists have more sensitive to buccal quarter and orthodontic patient and layperson. Orthodontic patients are more sensitive to buccal quarter than the layperson. It is only necessary for orthodontists to consider reducing the patient buccal quarter when the patient BCAR is greater or equal to 15%. Most researchers focus on the perception of orthodontists and layperson in smile attractiveness assessment, failing to pay attention to perception of orthodontic patients. However, the opinion of orthodontic patients are precisely the one that need to be considered the most. The perception of orthodontic patients still needs to further research on the aesthetic of the buccal quarter in a different facial type. This is the last journal that I'm going to review, which is Does Orthognathic Treatment Improve Patient Psychosocial Well-Being? Prospective orthographic patients have more symptoms in their head and neck region than young adults not needing the treatment. Patients' self-esteem seems lower than the control, but may only be true for female patients. Orthognathic treatment seems to improve the well-being of the patient. The recent meta-analysis concluded that orthognathic treatment results in improvement in orthognathic quality of life that can be detected 6 months after surgery. Especially social aspect, facial appearance, and oral function improved from before treatment to 6 months after surgery. Ashton James and Chemke Dreyfus suggest that sustainable improvement in daily effects should not be expected following orthogonadic treatment. Cross-sectional study by Lin suggests that at least positive improvement in quality of life are maintained for a longer period. The results suggested in general, psychosocial well-being decreases from pre-treatment to the application of orthodontic appliance and then increase until 1 year after surgery. 1 year after surgery, patients' psychosocial well-being was comparable to or even better than the control. The focus of the current study is to report changes in patients' psychosocial well-being until the post-surgical orthodontic treatment is completed, allowing for comparison between 1 year after surgery at the end of the treatment. The main interest of this study was to find out, does orthogonadic treatment improve the psychosocial well-being of the adult with severe dentofacial discrepancies? The method. Patients referred to two university hospitals for evaluation for orthogonadic treatment needed were recruited to study. Data was collected 6 times. Before treatment, 6 to 8 weeks after the placement of orthodontic appliance, 3 to 4 weeks before surgery, 6 weeks after surgery, 1 year after surgery, after completing orthodontic treatment. At the first data collected, 60 prospects of patients participated, and at the last data collection point, the patient group consisted of 15 patients. Data were collected with 4 questionnaires: Orthogonadic Quality of Life Questionnaire, OQLQ, Rosenberg Self-Esteem Questionnaire, RSES, Acceptance and Action Questionnaire 2, AAQ2, the Symptom Checklist 90, SCL 90. Orthogonadic Quality of Life Questionnaire, OQLQ, consists of 22 items that forms the subscale of the oral function, facial aesthetic, awareness of the dental-facial aesthetic, and social aspect of the dental-facial deformity. Rosenberg Self-Esteem Questionnaire, RSES, has a 10-item questionnaire with a 4-point Likert scale, where the higher score indicates the higher self-esteem. Acceptance and Action Questionnaire 2, AAQ2, AAQ2 is the 7th item questionnaire for assessing psychological flexibility. The Symptom Checklist 90, SCL 90, has a 90 item that form the following scale: somatization, obsessive compulsivity, interpersonal sensitivity, depression, hostility, anxiety, phobic anxiety, paranoid ideation, psychocytism, Global Severity Index. At the first data collection point, 60 prospects patients participated at the last data collection point, and the patient group consists of 15 patients. Discussion. Specifically, after beginning the orthodontic treatment, patients experience a deterioration in their oral function, self-esteem, and psychological flexibility, and an increase in psychological distress. Although improvement in self-esteem are cited as a motive to start the treatment, in this study, patient self-esteem drops after placement of the fixed orthodontic appliance, but then returns to baseline level and does not improve. Thus, the treatment does not seem to fulfill patient expectation in this respect. Interestingly, general psychological distress differs somewhat from these trends and seem to be better 1 year after surgery than the baseline. However, these improvements are lost by the end of the treatment. The only improvements maintained at the end of the treatment are found in general orthogonadic quality of life, oral function, facial aesthetics, supporting recent finding by the Toger-Bratton, who reported improvement in oral function, dental, and facial appearances 3 years post-surgery. The result also support the result by Poland, who found the improvement OQ-LQ in patients treated 4 to 8 years previously, as we find the changes both in functional and aesthetic issues. Thus, it seems to be orthogonadic treatment is beneficial to patients wishing for improvement in function and aesthetic, but not for those who hope to achieve improvement in their psychological well-being. These are the 3 journals that I have reviewed, and thank you for auditing.